Welcome to this edition of the ASHA podcast. I'm Fred Wyatt, Director of Communications with the American Sexual Health Association, ASHA. Today, we're talking about a common condition for many women, chronic pelvic pain, which can stem from a host of causes, and it can really limit a woman's activities, sometimes leading to a pretty significant reduction in the quality of her life. It's a big issue, and it's one that I find complicated because chronic pelvic pain is an umbrella term. As I mentioned, there's no one cause, no one specific approach to treatment. So we're going to begin sorting it out with our guest today, Dr. Karen Tang. Dr. Tang is a gynecologic surgeon, and her practice is Gynecology Specialist of Philadelphia. She's an expert in the diagnosis and management of chronic pelvic pain in women, and she has some wonderful patient education videos online that we'll talk about in a bit and we'll link to in the description for the podcast. So, Dr. Tang, thank you for spending some time with us today.
Thank you so much, Fred. I'm so happy to be here, and I just appreciate ASHA inviting me to have this opportunity to talk.
Well, we're really thrilled to talk with you. This is long overdue, so let's just jump right into it. What do we mean when we talk about chronic pelvic pain in women? I mean, what are some of the common causes?
Great, and I just want to say that was a beautiful introduction. You sort of you figured all of the things I'm going to be saying. As you said, chronic pelvic pain is an umbrella term. It's very general, and in general, it's a very complicated topic that often is related to multiple different causes. So usually when we say someone has chronic pelvic pain, it's not that we're going to find one diagnosis or one disease state that explains everything. It really is a multifactorial situation, and very few things in medicine are like that, where we almost expect that there are going to be many things involved. Just as a quick definition, when we say chronic pelvic pain, we sort of have this arbitrary cutoff, about 6 months or longer, that a woman is experiencing pain that's affecting her quality of life and affecting her ability to function or perform the activities that she ordinarily would do during her day, such as working, going to school, and including things like sexual activity. It affects a large number of women, and so in the studies, it shows it could be up to 15 or even 25% of women. I would guess it's actually even underestimated because so many women don't even think to complain about some of these symptoms. They just sort of say, I always have these issues. It's just I have to sort of deal with them.
Yeah.
And sorry.
When you mentioned that it's underreported, I wonder, is that partly because maybe sometimes it's embarrassing to even bring up?
Exactly. A lot of issues, particularly in terms of sexual activity, women are just like, I just don't want to bring this up. Who would I tell about this? A lot of people, even with a gynecologist, may feel very embarrassed or, say that I just have to deal with this. Isn't something that a doctor is going to want to hear about, or they don't know who to talk to about it. As we'll talk about in the different causes, sometimes there's so many different symptoms, they don't even know which doctor to see about it.
Okay. Can you tell us a little bit about, you mentioned sexual functioning and the impact chronic pelvic pain can have, so talk about that a little bit. What do women commonly experience in that aspect of their lives?
Absolutely. And so I'm a gynecologist, so a lot of women will mention that, the pain that they're experiencing is affecting their ability to participate in sex or to have intercourse. For women, just because sexual response and arousal, orgasm are so tied to psychological and emotional factors, obviously things like a pain experience, even if it's not specifically related to the pelvis, can affect their sexual experience. But particularly with chronic pelvic pain, because so many of them affect things like the pelvic floor muscles, which are the muscles that surround the vagina, and also the uterus, the ovaries, the pelvic organs, even things like the bowels, which are in the pelvis. But people don't, think of particularly as being tied to sexual function. If you're having pain in the area of the pelvis, can really cause significant pain with intercourse. When we talk about pain with sex or intercourse, we kind of divide it into like when they have the pain. Is it with penetration initially? Are they not even able to have any sort of penetration? Is it with deep penetration? So part of the questions that we ask when we see a patient will help to kind of, elicit the possible causes that could be contributing to the pain. And so oftentimes when a patient comes to see me with chronic pelvic pain, I always ask about sexual function. Do they have pain with sex? Are they having any issues with sexual activity? And oftentimes the response is that I haven't even been able to have sex. I'm in so much pain I can't even do anything. anything. And so, you start with kind of just at that point, and then you hopefully, and we'll talk about treatments later, get patients to the point where they're able to very comfortably participate in sexual activity.
And when I was listening to you, I was wondering if there's something of a double whammy there. I mean, not only is a woman who's experienced this going through what sounds like it could be a considerable amount of pain and discomfort, but then there's probably the psychological and emotional stress and then the strain on the relationship. I mean, this can really just like a domino effect, right?
Exactly, absolutely. And then later you had a question that we're going to be talking about the role of the patient's partner and a woman's partner. They become really intimately tied into this experience because of the pain and the impact on their relationship. I did want to go back. I realized I didn't kind of fully go into your question about the different causes of chronic pelvic pain. We've sort of touched on a couple of them already. As you said in the introduction, chronic pelvic pain is often related to many different diagnoses. So a lot of women will have several different conditions, and usually I actually tell people, even before we start off, that I expect to find at least 3 or 4 different conditions that are happening at the same time. And so, we talk about everything that could be in the pelvis. And so a lot of women come to the gynecologist first because they're like, well, clearly it should be a gynecologic issue. There was actually a large study of women coming to a GYN clinic in the UK for pelvic pain, and they found that only about 20% of them actually had a GYN cause. The most common causes actually end up being related to the bowel or the bladder. So there's a condition called irritable bowel syndrome, which is extremely common, especially in young women, and also something called interstitial cystitis or painful bladder syndrome. And what those two things are, many people may have heard of irritable bowel syndrome, but basically it's a condition where patients have pain with a combination of things like constipation, diarrhea, or both, and they have pain with having a bowel movement or actually relieved by having a bowel movement. And interstitial cystitis is a condition where the bladder becomes inflamed, and basically these women report feeling like they have a urinary tract infection all the time. A lot of these patients have called doctors repeatedly for antibiotics, for UTIs. They feel like they never quite get better. When I ask about those symptoms, a lot of women would be like, oh my gosh, yeah, I do feel like I have that. These are extremely common but very underdiagnosed because, again, like you said, a lot of these are kind of embarrassing symptoms and people don't feel comfortable bringing them up with a doctor, so they sort of fly under the radar until a doctor specifically asks, do you have these symptoms? And they sort of, their eyes light up and say, of course, yeah, actually, I've had all of those. So those are 2 big areas that are very common causes. In terms of gynecologic causes of pain, probably the most common cause is something called endometriosis. About 1 in 10 women has endometriosis, again, very underreported and underdiagnosed. And what it is a condition where the cells that normally grow inside the cavity of the uterus, these are the cells that actually come out like menstrual blood every month. They grow and they're shed every month as menstrual blood. It's supposed to only grow inside the cavity. Endometriosis is a condition where the cells grow outside of the uterus on the linings of the pelvic organs. So they can grow on the ovaries, they can grow between the uterus and the rectum, they can grow on the bladder. Actually, yesterday I just did 3 endometriosis surgeries and found them, everywhere, bladder, ovaries, linings of the pelvic organs. There's an associated condition called adenomyosis, which I call a cousin of endometriosis. And what that is where the cells grow actually into the muscle of the uterus itself. So they don't grow outside, but they're growing somewhere they ought not to inside the actual uterine muscle. And then there's actually musculoskeletal causes of pain. And this is actually something that many people don't think of. When they think of having pelvic pain, no one thinks that there's muscles there. Many of your listeners might have heard of something called Kegel exercises, where we tell people to kind of strengthen the muscles inside the vagina, and actually helps with things like leaking and continence. But some people may not realize is that you can actually have overspasm of those muscles, and that can be a cause of pain. In fact, it's extremely common. It's something that I find very, very frequently when I check an exam on women who have pelvic pain. And the reason is because those muscles are located right next to everything else, next to the bowels, next to the uterus, next to possible endometriosis. And just like many things can cause irritation or spasm of your muscles in your back, in your legs, your arms, anything that can cause irritation can cause those muscles to spasm too. So they're often related to having other conditions. They're kind of caused by other conditions. They're actually sometimes caused by common things just like exercise. I found that a lot of women who do a lot of running or certain repetitive exercises where they're doing a lot of motions with their legs, because some of the leg muscles are actually located in the pelvis, that they're actually causing those muscles to get really irritated, and that's a very common cause of pain, which a lot of people don't know about. Even other gynecologists may not know about that. And then very rarely there's things like actual like nerve problems, something called a pudendal neuropathy. Those are very rare. It's something we keep an eye out for, but most of those other things I've discussed are much, much more common. And you touched a little bit before on the impact in terms of depression, anxiety, relationships. There's an extraordinarily high association with having psychosocial issues in women with chronic pelvic pain. And I say it's like a chicken or the egg. Women who have pre-existing depression and anxiety do have a predisposition to experiencing more pain. And then also women with pain obviously will feel depression and anxiety because they're so distressed at having all of this pain. So a huge percentage of women will have depression, anxiety, also things like substance use or abuse related to the pain. So when we talk to women with chronic pelvic pain, we're asking about all of these factors as well, not just their physical symptoms, but also psychosocial and lifestyle issues.
That is a lot to unpack. I knew.
Sorry.
No. It's wonderful. I mean, as we referenced in the intro, I said it's an umbrella term. It's very complex, but I'm really beginning to see there's a lot of dimensions to this. So the next question I was going to ask is about treatment options, and I can just tell that is not necessarily straightforward either. And you mentioned that women can have like multiple things happening at one time, so it probably is a mixed bag with treatment too, I'm assuming.
Absolutely. And part of the thing that we do when we see a woman for consultation for pelvic pain is we sort of lay out a framework for it. Part of the difficulty with an experience of chronic pelvic pain for these women, it just feels so chaotic. It feels like there's just so many things happening. They don't know what's going on. And a lot of doctors, too, will feel a little bit overwhelmed when some of these patients come in because they have so many symptoms.
I bet.
And so part of what we do that helps kind of start the treatment process is we actually just try and organize it, and we make a plan. I always tell people we're making a plan of attack. And so and I tell people that they're going to have several things that they'll end up needing to do and that we'll need to do with them to help manage this process. And so I tell people, number one, we have a treatment team. It's never just one doctor doing one thing that's going to fix everything. Because so often people have 3-4 diagnoses, I tell them they're going to have a good primary care doctor, a good GI doctor, a mental health professional. And that's one that I think a lot of people are surprised that we bring up, but it's so important to the treatment process is to have a good mental health professional that's assisting them. And then oftentimes we're sending them for something like called pelvic floor physical therapy, which again blows a lot of people's minds. They've never even heard of that before, but it's extremely commonly used by pelvic pain specialists, just because so often there is a muscle condition. They also help, too, with things like the bowel and bladder habits. Actually, they help with things like chronic constipation or bladder issues. And so I tell them, number one, we assemble our treatment team. We figure out who they need to see to address each of the different components. And then we address the different, we call them modalities of treatment, meaning that we think about medications. There's a whole slew of different types of medications that could be used. Things like birth control to control the periods. People who have really, really painful periods, we suppress with different types of hormonal birth controls, birth control pills, the Mirena IUD. Antidepressants, both actually for depression, but also for the pain. Antidepressants actually function in some way as pain medications. Interestingly, they may function somehow in the brain in terms of processing of pain or on the nerves. Things like muscle relaxants. There's something called gabapentin, which is a medicine that works on nerve pain. And we try to be very sparing with narcotics. And I was going to talk at the end probably about something like the interplay with the opioid epidemic and just in general how people experiencing chronic pain in sort of their desperation to find something that will take the pain away, start on the path of dependence or addiction to prescription opioids. So we try and obviously nowadays be very, very mindful of really limiting the use of opioids and just using them very sparingly to sort of as an adjunct to all of these other more effective and more healthy treatments. And then, sometimes people will need a surgery. Especially for something like endometriosis. Endometriosis is diagnosed surgically, meaning we perform what's called a laparoscopy. We put a camera through small incisions. We inspect the pelvic organs, and if we see endometriosis, we remove it surgically. And then we use a little bit of kind of unique ways of giving medications, things like vaginal suppositories. Some of the medications we give for pain can have lots of side effects. It can make you feel kind of sleepy or sedated. So sometimes we actually give them in a vaginal form that will be effective and get it near the pelvic organs, but a little bit less impact on kind of making people feel a little bit sedated or sleepy. And so, like I said, we try and kind of attack each component of the possible pain sources. And I tell people, in that way, we sort of chip away at each bit that could be causing them pain. We may never get them to zero pain. A part of the treatment also has to do with managing expectations, and again, sort of, giving a framework. And then, right off the bat, I like to tell people, just so that we don't set them up for disappointment or failure, that we may never get them to zero pain. The goal is control of pain, and to get someone to, a good quality of life, being able to do all the activities that they want to do, to be able to be sexually active and enjoy sexual activity. It may not be that they feel absolutely nothing. Kind of setting that expectation in the beginning is helpful, because I think sometimes people feel very disappointed or discouraged. They feel like I'm still feeling some pain, like this may not be working. So having that kind of expectation that you're actually doing fine, we're actually doing really well. You and I had kind of joked a little bit about before we started the podcast about celebrating the small victories. I told you have to celebrate the small victories. You celebrate the improvements that you achieve, and don't be discouraged by the small setbacks. So like I said, that's the whole kind of approach to the treatment. It's a big one. It's a broad one, and we use different approaches, but that's how we get the best success rates.
So let me ask you for some practical advice here for the women listening to this podcast. What are some tips for women who may be experiencing chronic pelvic pain when it comes to talking with their healthcare provider, to broaching the subject and how to talk about it? Any insights there?
That's a great question. And I feel like women who, come prepared and have that, ability to kind of think through what they're going to be talking about with their healthcare provider, you're already a step ahead. You're already you've made one kind of small victory, just, number one, committing to seeing someone about it. And like we talked about, even knowing that there's something you can do.
Good point.
And coming prepared is actually great. What I tell people when I first see them is to actually do something called keeping a pain diary, meaning like you literally note down, when do you have pain? When is it most severe? And are there certain things that are making it worse? Are there any associated activities, foods, anything you've noticed that are causing potentially the pain to be worse? And you may not even notice that they're, related, but when you keep the pain diary, you actually will start to see these patterns that then can be very helpful in terms of, talking to your provider. So I tell people, think about what you ate and drank that day, what was happening with your bowel or bladder function. Did you do any certain exercises or activities that day? Did you try to have sex? Were you at a certain point in your menstrual cycle? Any particular stresses? And just kind of noting those patterns can actually even help you see, figure out who to see. Sometimes patients are just so confused as to, which doctor do I even see for this, that they may notice, wow, actually a lot of these pain experiences are with my bowel function. Oh, I should see, my primary care or a GI doctor, or it's almost always when I have my period, or with sex, I should see a gynecologist. So step number one is just trying to get a little bit more information, and that will be really helpful too for your doctor to be able to kind of sift through, what could be going on. Oftentimes, when we first take the history, we already have, I feel like 90% of the information we need to kind of figure out what's happening. So having the woman, really kind of think through the details of what she's feeling will help with that process greatly. And then the other advice I'd give is to try and find doctors who specialize in chronic pain. They're more more likely to know what to look for in a history and an exam. General OBGYNs are fantastic. They have to kind of master a lot of women's health, but they may not necessarily be very experienced in doing a pelvic floor muscle exam. So my background is in advanced GYN surgery, and as part of that training, we do lots of training with chronic pelvic pain and endometriosis. And so, I learned to do a very detailed exam that a lot of general OBGYNs may not have that experience in. And then also, providers who are used to dealing with chronic pain patients are just a little bit more, it's a little bit more common and a little bit more, day to day. Sometimes if a patient comes in and they have just a lot of issues, a lot of complaints, it seems very complicated. And sometimes that's a little overwhelming for providers too. We're human beings. We feel that kind of anxiety that the patient is feeling.
Sure.
So seeing someone who's used to patients with chronic pain, it's a little bit more manageable. Like I feel like, when I sit down with a patient, I can say like, we're going to take care of it. We're going to handle it. You're going to be fine, which, sometimes if a doctor may not see a lot of pelvic pain or chronic pain in general, may feel a little bit overwhelmed by the information and, the patient's distress. So look for a doctor who specializes in chronic pain, and that could be a GI doctor, that could be a primary care doctor, that could be a surgeon or a gynecologist. So just in general, try and do a little homework on, what the doctor's experience is and what their background is. And then the last thing I'd recommend is just, understand that it's a process, and then that, you won't walk out of the door that day having something that's going to just completely fix everything. I call it like the house MD, like the TV show Expectation. A lot of patients think that they're going to walk in, they're going to find one mysterious, very rare condition. It explains everything. You do one treatment and it's done. It is much more of a process. And just to understand that, they're going to walk out the door with even more doctors to see and even more things to do. And that's how, that's the process. We start that, treatment plan, and they're going to have to go out and do some things. And like I said, they have a little bit of homework to do in terms of, what we would like them to, to pursue, like the physical therapy. But again, just to realize that, each thing that we recommend is going to chip away a little bit at that pain, and just to, to not be discouraged, and to know that, it's going to be fine. We're going to take good care of them, and that, we're just going to start that process together.
So before I let you go, let's turn our attention to something you mentioned earlier, the partner.
Yes.
So yeah, I mean, this is a key component. So what does the partner need to know to support the woman and maybe make her maybe ease the discomfort?
This is such a great question, and I think a lot of people wouldn't have thought to ask this question. I just love that you did. I'm actually really amazed how often patients come to the doctor with their partner, and I tell them, and I really congratulate them, because it shows that they already have a good enough relationship that the partner feels comfortable enough talking about some uncomfortable stuff, and supporting this woman as she's going through a very difficult time, and just to say that, to one, obviously have some understanding and compassion for, the woman who's having so many things to deal with, obviously in distress. I tell the partners when they come in that, they're sort of as much a part of it on the day-to-day as the patient is. They're seeing them suffer. They're seeing them have this discomfort, and obviously, it's affecting sexual activity that, that's affecting their quality of life as well. And so, I tell the patients sometimes too to be mindful of how it is affecting their partner. I think a lot of people who are going through chronic illnesses sometimes, not unleash, but they know that their partners and loved ones love them, and that they're a safe place to kind of to complain or to express their frustrations. And sometimes they may not necessarily realize that it's affecting their partner and causing a lot of stress as well, and that they're feeling this experience of discomfort and distress just as much as are in some ways. So there's a little bit kind of on the part of each partner that they have to have some understanding for the other, to know that this is something that they're going to have to support each other through, and to have some compassion and patience. And I tell the partners too that they may actually benefit from counseling as well, just like the caregiver for any patient going through a serious illness. They're going to have a lot of frustrations and stresses, and so they may actually want to consider seeing like a therapist psychologist to help with processing this whole process as well. And then just to work on communication, to talk about their needs and what they need from each other. And so I always tell them, again, if the partner is actually there with them, they've already kind of, took that first step of coming together and working as a team on the whole, on the whole treatment. And so I love that. Actually, I really congratulate them when they come in like that. I say, it's a sign of a fantastic partner that they're so understanding.
Absolutely, and I was really encouraged to hear you say that. I would have thought the opposite. I wouldn't have expected that many partners come in, but I'm glad to hear that they do.
Yeah, I actually, it's interesting. Of all the conditions that I see the patients for in the office, I feel that the most common situations where a partner comes in is actually when they're having pain. The endometriosis patients, things like the irregular bleeding and other issues. Like I think a lot of times the partners aren't so comfortable coming in for that. But interestingly, a lot of the partners do kind of come in for the endometriosis consults and the pain consults, and you can see their concern when they're sitting there and supporting their partner, which is great.
This is really fascinating. We've been chatting with Dr. Karen Tang. Her practice is Gynecology Specialist of Philadelphia, and the website for her practice, you can find her online at philadelphiagyn.com, philadelphiagyn.com. And earlier I referenced her patient education videos, and you can find them there. So, Dr. Tang, this was fascinating, illuminating. I mean, pelvic physical therapy, who knew?
I know. That's what a lot of people are like, I didn't even know that was a thing, and we use it so often. It's such a great method, too. And I also wanted to point out, we actually recently have started some Instagram accounts for both myself and the practice, and we put a lot of women's health information. Actually, that's how I first met Fred, is when we were putting up some information for Cervical Cancer Awareness Month. And so it's at Karen Tang, MD, KarenTang, MD, or at Gynecology Specialist. And so we put a lot of information on women's health, including things like, on pelvic pain and issues with the sex and physical therapy, and also some surgical videos as well. People may be interested in seeing, what is endometriosis, what does it look like, what is a surgery. So people really seem to think that those are kind of interesting. So hopefully people will check it out.
No doubt. Well, thank you for spending some time with us today, and hopefully I can convince you to come back and talk some more.
Absolutely. I would love it. Thank you so much, Fred.
Absolutely, our pleasure. And thanks also to everybody who downloads and listens to this podcast. We'll have more to come, so check back often. We're online at ashasexualhealth.org, and of course, follow us on Twitter and be our friend on Facebook. You can also sign up on the website to receive ASHA's update emails, and we'll let you know when new resources like this podcast with Dr. Tang, when they're released, you'll be the first to know what's happening. So connect with us that way. Until next time, this is Fred Wyant for ASHA. So long, everybody.